Well, welcome everyone. My name is Brent Malacote. I serve as the Associate Superintendent at the Sacramento County Office of Ed. Although I'm joining you from home today, feeling a little under the weather and trying to recover a little bit. So excuse my voice but as David said when we were kind of doing our pre check-in, I'm sure this will get my energy level back up and I'll be feeling rejuvenated. Usually do as a result of these meetings. So just want to say thanks for joining us and thanks for taking the time. I really love this graphic. I think that there's a kind of an intersection of goals that we have for this community of practice that are all represented here, but we want this idea of building a shared understanding. We know that we've got to do that through thought partnership and learning. I think that we've been saying all along, while Santa Clara and Sacramento might be on paper the ones that are leading this initiative. We know that without all of you, we wouldn't go anywhere. So we're learning right alongside you. We came into it with a lot of we were humble in our learning and in our approach, and so we just want to thank you for continuing to kind of lean in on this. We know that sharing best practices is going to be important on this, and also showcasing COE efforts and approaches. And really, I want to we've got Kathy King and Teresa Stevens, along with a couple district partners from Riverside County Office of Ed. I'm going to let Kathy and Teresa introduce the district partners when it's that time for them in that time of the meeting. But just really, there's some great work happening in this space across the state, and we're so happy to be able to showcase it, to spotlight it. We'll continue to do that in these meetings. But here are our goals. We hope that you'll see that we continue to kind of lift these up at every one of these meetings as we move on from month to month. So just thanks to everyone. So let's keep going. Here's our objectives. I think they really kind of maybe highlight and underline the goals from before, but we want to continue to ground the work in the power of thought partnership and collaboration to enhance schooling behavioral health services. We want to learn from one another as we're trying to figure this out, this fee schedule and all the operational readiness that needs to come along with it. And we want to gather your input to inform future TA and support. And that'll happen, I think, throughout the meeting today. And we'll have an opportunity. There'll be many opportunities for you to give us feedback. And we take that in every meeting as we're preparing for the next. We're doing our very best to incorporate as much of that feedback in as we can. So the information that you share back with us is really important, and we continue to use it. We can go on to the next one. Oh, here's a few housekeeping items, which I think you're probably all becoming pretty familiar with. I need to follow my own advice on this first one. If you would put your County Office of Education next to your name, just by renaming yourself in this Zoom meeting, that would be great. We have both a link and a QR code here to be able to engage throughout the meeting. We'd ask you to do that. It's a Google form that we've created just to continue to kind of gather that feedback, both for kind of as the meeting's going on, to be able to answer questions and those sorts of things, but again, also to improve as we move from meeting to meeting. And you probably saw it as you came on, but this is recorded, and we record it so that folks that aren't able to join us because they've got another priority that they just couldn't miss, we want to make sure that all this information is alive and well and is available to them as well.
Kathy King is a director in the Leadership, Wellness, and Student Services Division for the Riverside County Office of Education. Kathy has worked in the field of education for over 20 years with an emphasis on positive behavior intervention and strategies, social and emotional learning, and wellness. Kathy has served as an elementary school teacher, literacy coach, site administrator, and district and county office director.
Thank you so much, Carissa. We are so excited to be here today to be sharing with all of you. And I just want to just say a big thank you to SCOE and the Santa Clara team for just giving us this opportunity to share a little bit about the work that we are doing around specialty mental health in our county. So you see some stats there on the slide just to give you some context of who we are. So we have a little over 430,000 students in our county. About 70% are eligible for free and reduced meals. We have 23 school districts and about 30 charter schools that are a part of all of our LEAs in our county. Today, you're going to hear from two incredible schools in our county who have really one, Jurupa Unified School District, who's really what we call the tip of the spear in this work. They were doing this work way before a lot of us decided to even kind of tip our toe in the water, if you will, and get involved with Medi-Cal billing. And then we also have Rafael Garcia, part of Moreno Valley Unified School District, who is also part of our mental health grants. And he just decided to take the bull by the horns, if you will, and say Moreno Valley is going to start building this system and begin to really look at the supports that they're providing to students and how can they do that in a way that's sustainable. And so without further ado, I'm going to turn it over to Jose to share a little bit about Jurupa Unified School District.
Thank you, Kathy. Before I start into the what of specialty mental health, really want to kind of talk about the why. Why did we go there? For us, it was a necessity. And so we're just going to do a little tour of history. Back in 2014 was when our department was created under LCAP funding, so parent engagement. And at that point, it was myself, and I had an administrative secretary for half-time. Our role was really looking at the needs of the community, engaging our parents, empowering our parents. But as we engage in the community, identifying what were the needs, looking at all of our educational partners. And, it was very clear that our mental health system and services and supports for students and parents was, I would say, not lacking, just not in existence within our community. Our behavioral health providers were always at capacity, lacked funding. When we launched, I would work with two agencies. They could support via Medi-Cal billing less than 15 students a year. We worked with other agencies that were contracted under our county mental health. And as we approached and had conversations, we were able to expand Medi-Cal allotment for one of our partner agencies, so they can now serve double, more 30 students a year under Medi-Cal. So as funding increased in Riverside County, agencies could not keep up with the need because we now established a system, a universal referral process. And so eventually in 2019, we became our own county provider. So this is where we were in 2014, and here in 2025 is where we are today. We are a system of braided funding, relying on specialty mental health for a bulk of our behavioral health services, grant dollars, and various funding streams that are targeted towards behavioral health. So we have our Mental Health Service Act, which is now the Behavioral Health Service Act under Prop 1, where we provide cognitive behavior intervention for trauma in schools. Our Mental Health Student Service Act, which is funding that goes to our County Department of Behavioral Health that we are subcontracted under. And then we work with, again, various partners, various entities, and we maintain the system of braided funding in this picture, our district funding for next school year allocates funding for 3 individuals. The rest are contract reimbursement and grants. And here is, in essence, our organizational chart. You see here on the left, that is all behavioral health. And you see our behavioral health team there on the left as to what this braided funding funds. Now, understanding, let's get to the what, right? Specialty mental health. We have to understand how LEAs are reimbursed or how we receive fees. So under Medi-Cal, we have the LEA BOP program, the small program. There in both is specialty mental health. We're going to focus on that. And of course, CYBHI. We have commercial insurance through CYBHI and the Behavioral Health Student Service Act Prop 1 that allows funding for schools and various grants. That is the stream of funding. You see this list in Medi-Cal. We're focusing here again only on specialty mental health. So when we hear Medi-Cal, understand it can mean any one of these funding streams, if you will. So specialty mental health is a fee for service. You provide a service and you receive that fee or that reimbursement specifically for that service. It is a fixed determined rate, right, by the Department of Healthcare Services and established under specialty mental health. For Jurupa Unified, our contract with our county behavioral health program is $3.8 million this year. So from 2019, we went from a $100,000 contract, increased services to 2015 to where we currently have a contract of 3.8 million. Now, we went to specialty mental health because CYBHI didn't exist, but now we're happy to tap into CYBHI and we're estimating our first year to be about $400,000. What districts need to understand and know about Medi-Cal? There's the county mental health plan. That's our county behavioral health plan. And then there's Medi-Cal managed care plans. So for our county, it's Kaiser, Molina, IHP. All of that is Medi-Cal. So as we learn into specialty mental health, you might think, but they're a managed care plan member, they're IHP. Can I bill specialty mental health? Remember, Medi-Cal is that funding line. So yes, if they have Medi-Cal, typically it can also go under specialty mental health if the service is appropriate for specialty versus the managed care plan. Remember, the managed care plans, they manage the Medi-Cal benefit for consumers. And I think that's the key takeaway. They're managing that benefit. Consumers can elect not to enroll with a managed care plan and simply just have what we call straight Medi-Cal. Again, the what and the why. So specialty mental health, we look at the rates. It's called specialty for a reason. You're going to be involved in a little bit more of a wraparound service. It's intended to provide a higher level of service. Here in red, these are just any of the clinical positions: social work, licensed professional counselor, MFT. Our rate in Jurupa is 261 under specialty. Again, we're required to provide a higher level of care. You see here under CYBHI and then LE BOP, the different rates. But remember, this is just part of the braided funding. We started there because the other options were not available. Here are the positions that are required for that higher level of care. We must have a peer recovery specialist, whether it's youth or partner. We have our transition age youth, so basically our TAE peers assigned to our middle schools and high schools, providing that extra support. They're that extra layer. And then our parent partner provides support across the district, working with our parents of our children receiving those services. Rehab specialist. The rehab specialist is providing some of those skills reinforcements for students. I want to pause here and I want everyone to kind of think and process. If we have students that are requiring skill-based services, typically, where is the go-to as to how we're referring students or where we refer students? Typically, that's been the special ed route. Folks asking for a one-on-one aid, folks asking for assessment. Oftentimes in our district, we're already providing the services. So therefore, let's process and think of a cost savings that having these services might later provide our school district.
Rafael Garcia is the Director of Wellness, Mental Health, and Community Outreach at Moreno Valley Unified School District. He oversees mental health services, family engagement, and community partnerships, as well as the Community Wellness Center, which provides essential resources to students and families, including those experiencing homelessness.
All right, thank you. I'm going to share a few things with you, but I want you to walk away with really big three key points, and that is our context here in Moreno Valley Unified School District, and what that means as far as the needs of our students. The second thing is how we utilize additional funding sources to braid and blend to support our students and have not just the traditional, the additional, but a comprehensive funding model. And then lastly, how you can also engage in this work, in the work that we do. And we're proud members of the Riverside County Wellness Collaborative. And we started our work there via a grant. And we were just proud of the work that this turned into. And I'm happy to share with you here on the next slide a little bit more about our students in our context. And so in this slide, you'll see that there's quite a bit of diversity here in Moreno Valley Unified. We have close to 75% now that students that are Hispanic, with 13% African American, white 6.3%, Asian, Pacific Islander, Filipino, rounding out our other student groups via ethnicity, but over 31,000 students across 23 elementary schools and 18 secondary schools. And our students are diverse student population, and they have substantial needs. We know that we are across the county, we have the most foster students, homeless students, and we are the third largest district in the county. And so having such a large need really encourages us, and I feel like there is a moral duty, a mandate to really work beyond just our immediate scope of trying to identify and remove those barriers to attendance. And so we have, you see our English learners and our students with disabilities there on the screen, but that over 25, close to 26,000 of our students are economically disadvantaged. And what that has led to is our chronic absenteeism, for instance, is among the highest in the county. I mentioned our homelessness and our foster, but also just transportation needs. When we meet with our families in our attendance meetings, we see that they have there's a barrier just to accessing physical, behavioral, wellness resources that maybe other students groups are able to access or other districts are able to access. And so if you look at just the center, that pyramid there, we're familiar with that MTSS, that multi-tiered system of support pyramid. And I want you to look at that tier 1, school-wide interventions. And as you move up in those tiers, you have a short-term targeted interventions, and tier 3 is long-term intensive interventions. In our district, you would have a lot of bigger students, more of a larger group in that tier 2. And that is that our students have substantial needs. And when you look at funding for those resources, we know as you move up and the needs are more intense, it's going to cost more. And so we need to find creative ways of funding those resources. On the left side of this pyramid, you see those traditional funding streams, the local control funding formula, ESSA, you see LEA billing, and ERMS way at the top, educationally related mental health services. And before we started our work to become a school-based health center, that was the only way our students were able to access mental health services through the ERMS, through educationally related mental health services. And what that created was an over-identification in their students with disabilities in special education. And it created a massive barrier for anybody else that wasn't going to be identified. There was no access in a school-based setting. And so today we want to talk about how we unlock that key here in Moreno Valley to the right side of that pyramid, where you see those additional funding streams due to the Mental Health Services Act, and how to tap into some of those Medi-Cal managed care plans and what, like Jose mentioned, Medi-Cal specialty mental health billing. And so as we looked at our student needs and what the resources that were available, and many of you might be districts that have for instance, a community school grant, and there's that needs assessment and resource mapping. We did a very similar thing as it related to this work in mental health. And what we looked at is that our program was not designed to meet the needs of our students. We looked at what our community was asking for, what was preventing them from showing up to school and really accessing their education. And our students, their needs were quite a bit more than what we could provide. And so we decided we were going to do this differently. Our board was very forward thinking. They actually created the department that I lead, the Department of Wellness, Mental Health, and Community Outreach. I'm actually standing here in our new Health and Wellness Center that is close to completion. We're just days away from our new opening of this facility with conference rooms and a laundromat and showers. And so in order to scale up, we really had to understand the context of our community. And so this is part of the journey, is understanding what are your needs in your community. We went to IEHP, for instance, the Inland Empire Health Plan, and they were able to pull zip codes in our area to find out how many families, how many people in our community would qualify for full or are eligible for Medi-Cal. And we learned that over 36,000 folks were actually Medi-Cal eligible. And so they were really interested in a partnership. We leveraged that to also obtain a contract with Riverside University Health Systems. And then, of course, the CYBHI, the Universal Fee Schedule. We are part of Cohort 3, so we'll start accessing that as well. And then through the work of government grants. And so in order to sustain our resources, some of the resources I just mentioned, we've had to truly blend and braid across just different funding sources. But we've also leveraged that with amazing community partners. You see on the screen there, the California School-Based Health Alliance has just been a wealth of information for us. The Inland Southern California United Way with many contributions as far as school supplies and wellness kits and parent workshops in all areas of wellness. And Feeding America is our largest contributor for our food pantry. And so we provide meal kits for our families in need. We have district-wide food distributions, but we also provide meal kits on a short-term basis for our families. And then like Riverside Community Health Foundation provides additional parenting resources, parenting workshops. There's actually academies where our parents take part in lowering their BMI, for example, their body mass index, if they have type 2 diabetes. And there's like a whole academy and program designed to measuring their success in that. And so as we're seeing these resources become more available in a centralized location, what we call that one-stop shop, our families, that trust that our families have developed with our center, we're able to now leverage academic interventions as well and have tutoring available here on site. And so as you're able to fund all of this work, it has like a exponential effect, if you will, on your program's capacity. And how do we start this work? And so this was something that as I look at this slide and I look back at the beginning, I remember thinking, I was a principal, I was a social studies teacher, I was not a clinician, I was not in that medical field. And so there's been quite a bit of learning, and I did benefit from having, like Jose or the Riverside County Office of Education, but it's so great that we are in these spaces now, because one of the first steps you need to do is just to build your internal capacity to understand specialty mental health. Establish relationships with your county children's behavioral health director. It is very, very important that you have that relationship. It's something that really extends beyond having a third-party administrator, because they're in your local community. And so they'll have a better understanding of what the needs are in that community. And you can also connect others with the work. It is complex work indeed. And identify and develop a district team to lead this work. This is not siloed work. This is something that I go across our human resources department, business services, ed services, And we are all impacted by this work. So it might be a new position that needs to be created, and I need to make sure that the sustainability is there, that human resources understands the qualifications that are needed, and how it impacts our students and their families. And so this is a very collaborative approach. Step 2 is you have to know that your Medi-Cal requirements. This slide here, the stuff you see on there, I remember when I went back and had to engage in this work. I mean, it could be overwhelming, but tap into some of the folks that know this work already, have that clinical background. I'm very appreciative of our head of service, who just has extensive experience in the medical and the clinical world. And this was like a second language to him. So the National Provider Index number must have the location of where you're going to provide services at. The local educational agency, or the LEAs, you may already be engaged in this work via the LEA BOP. You may already have an NPI number. We decided that we were going to apply for a new one just for specialty mental health service billing. Because if the service location is not at the district office, if you're not located there, then a new NPI number is recommended. And you will then, as you're having that relationship with that director in the county office of mental health, they'll provide a process for contracting with them. There's a program statement that you submit, and then they'll let you know if it's a bid or is it an open contract process. All of your staff would have to register for a Medi-Cal under the PAVE portal, and that PAVE registration is for all licensed staff, or your clinicians that are providing the services. Staff must also be registered under the Board of Behavioral Sciences. And DHCS registration for Medi-Cal eligibility verification is done. And eventually, once you get your contract, you can also have a third party that provides that service as well, to make sure that Medi-Cal certification is active. Step 3 here in the Medi-Cal certification is just to work with your county staff for Medi-Cal certification. This bullet here is probably the easiest one. They come out, they do a recent, they make sure that the fire clearance passes for the facility that is being used, that you obtain that letter on file that you've cleared your your fire inspection, and then you submit all applicable board policies. And we've actually had to draft new board policies just to ensure that the work that we're engaged with our county office of mental health, as far as student confidentiality and funding and some of the things that we're doing, is approved by the board. And then you, of course, want to identify the location for service and display copies of staff licenses, as well as county procedures and regulations. And I joke with our clinicians because those copies keep getting bigger and bigger. And I'm thinking there's like a little mini competition, I think, as far as who can print out the largest copy. And the step 4 that I'm going to cover is just building internal capacity to provide services. Internal capacity building as far as job postings. I meet with our recruiter here in HR because she may not understand what a license means or what education is required, the license world versus the credential world, and what exactly is needed and how long do they need to provide service before they're considered a clinical supervisor, for instance, is something that we've had to sit through and actually put into their manual as well. Whether positions are going to go the classified route or certificated route. We know that our certificated staff, it's very clear they must have a school credential to be in that as a bargaining unit. But our classified staff, also our CSEA, which is over the classified side of the house, they were very concerned about the licensed folk joining their unit and going straight to the top, and it really being something that, and as far as the payroll, the salary schedule was concerned, and other members not being able to access that. And so when you sit with them, you clarify what the experience and education is needed, and then your business person is always going to want to make sure that there is a the sustainability to each of these positions, that this is not like any other grant. So that fiscal understanding of the program is imperative. I can't tell you how many conversations, emails, meetings we've had where we've explained the projections for specialty mental health, for CYBHI, and how they can be sustained through billing. Now, it's different than a grant, where a grant, perhaps it's about time reporting and time accounting, but you're paid for positions. When you get involved in this work, productivity is something that is measured, and it is something that you need to monitor regularly, so that the funding sources are always being generated.
My name is Liz Gomez. I am the Director of Health, Wellness, and Strategic Initiatives at the Sacramento County Office of Education. At this time, we're going to head into our Q&A. So David and I will help facilitate that. And gratitude to Jose, Rafael, and Kathy, and Teresa, who will be here and ready to answer questions. So we have the Google form, which will pop again in the chat. And we'll also take raise hands as well. So David, shall I grab the first question from the Google form?
I think that's a great idea, Liz. Thank you.
Okay, sounds good. Question for Riverside/Jose. As specialty mental health providers, are you able to or required to provide services when school is not in session, e.g. 12 months per year?
Yes, specialty mental health falls under a medical model. Therefore, we do push into our extended learning for summer school. June is quite busy. And then we work with parents during those drop-offs, like July as a drop-off. So we're really trying to work and make sure we have our sessions in, or that's when we recommend our staff to take their vacations.
Great. And then you're also, I would assume, providing services after the instructional part of the day, afternoons, evenings.
So as a specialty mental health, we do have extended hours beyond our traditional. So we're open till 5, but we adjust based on parent needs. If we have clients that are coming in, typically we can adjust to 5:30, 6. Most do want to be seen during the school day. That's the purpose and benefit of school-based mental health and having a specialty mental health program within the school setting. So we don't have too many evening appointments. In times where we need to, we fluctuate, and we do have satellite offices, so we are able to meet the need regardless of where the space is needed for us to meet with students and families.
That's great. Yeah, because I just think of the after-school space as well, just making a larger continuum. So that's great to see that you can lean into that as appropriate or necessary.
Well, and actually, I'm going to echo on that. Like, we just had a meeting this morning, and so I shared with my team and said, hey, let's connect, because remember, we have space after school, so we'll be using classrooms because we had some space issues. And so we talked about just, well, we'll do more after school. That's all.
Yeah, well, that's great. I mean, really, because you look at ongoing sustainability models, right? So if you build it out, you build it, they will come because the need is there. And then we just need to link the funding to the activity, because kids learn 24 hours a day and they need 24 hours a day. So that's great. All right. If you have a question, folks, feel free to raise your hand, or we can go to and from the written questions. Liz, do we have another question that's written?
We do, and so Jose, Rafael, I know you're in cohort 3 of the fee schedule, and Jose, can you remind us, are you in one of the cohorts of the fee schedule?
Cohort 1.
Cohort 1. Okay, so we'll ask this question and feel free to let us know if it makes sense for y'all to answer. Could we explore staffing implications for districts for the multi-payer fee schedule? How do we support human resource departments in negotiations as we navigate through this?
So here in Jurupa, I have been working with our human resource office to look at work years. So we have a variety of different work years. I have requested to define new work years to meet this new demand, if you will. And CYBHI, given that as we're serving students that do want to drop off, so we have a population that only want services during the school year when their anxiety is a little bit higher, or that's when they're, if you will, feeling more of the symptomology. We've adjusted staffing so that we have some behavioral health staff that are working during those times that students want the service. So here we have in Jurupa a variety of different work years based on the need. So we did modify and adjust to meet the need and the demand of CYBHI and of only wanting services during the school year. We don't know until we do the assessment and are working with the family as to the extent of the services and if they want to continue beyond the school year or want to end, but we had to fluctuate and address the need.
Yeah.
And I'll just say that,
Oh, go ahead, Raphael.
oh, sorry, I was just gonna say that for Moreno Valley, there was a lot of learning involved. I made friends with HR and business, and we sat together and looked at what do we need to meet the needs of this program. And I learned so much from them as far as how they staff, what Jose mentioned, the academic years, which one we could use, how we could get creative. And then after that, we brought in our association leaders, our presidents, and they also worked with us to see what this means. Does this mean now that we're going to be generating a ton of money, and is this going to be something they're going to want to negotiate? And so we had to really clarify what this is, what it's not, our projections, and be very transparent and collaborative with them.
Oh, that's great. I'm thinking about really the relationship with HR is going to be really important too, as we start talking about what's allowable and people's expectations of work. And I know that we've had that come up in a few different spaces. So in that process, Jose and Raphael, how did you develop those job descriptions that would then authorize or empower management to support service providers to do the documentation, the kind of the administrative paperwork that sometimes the union agreements can be a barrier? Do you have ongoing development? Can you talk a little bit about maybe how you work with union leadership to alleviate some of that stress?
Sure. In Moreno Valley, I can speak about our process. We have something called JFMC, our Joint Fiscal Management Committee. And so we meet quarterly or as needed, but usually it's quarterly. And we project our positions. We go over funding, and there's a ton of questions that they have over these positions that we've brought in. We've gotten our so for specialty mental health, and Jose has been such a great help in this area as well, and all these areas. We had the contract stipulates you need to have, for instance, a peer specialist, a TASE, what they call TASE, a transitional age youth, and parent partners. And so with the certifications that they need, we include that in either an existing job description, or what we did is we just developed a brand new job description for that. And so with us, it's, really educating the board, district leadership, and then bringing in directors and their staff so that people know what this is about and how it's going to impact those working conditions for each of those individuals.
Oh, that's great. So we talked about that in one of the groups too, that the importance of letting folks be reminded of it's also about sustainability for their LEAs and their workforce, right? Get the union to understand that it's a partnership for services for youth and sustainability of collective bargaining members. Yeah, Jose?
Yeah, likewise, when we launched, we visited every school district in the Inland Empire that had specialty mental health. We looked at their postings. We looked at county postings. So we had to create postings that were accurate as to the demands of the position, the licensing. And then we had conversations of certificated versus classified. In Jurupa, our positions are under the Classified Association. Each district has different reasons as to why it would go one versus the other. But in Jurupa, we went with the classified association on creating those positions. And then we work on them all collaboratively.
That's great. Thank you. Liz, do we have another question that's written?
We do. So I'll just say, Corrine from Glenn, we will be answering your question during office hours. So we've connected with DHCS about that. And so I'll go ahead and head to San Luis Obispo. How did you get your clinicians on board? Seeing the need to build practitioners' capacity to provide evidence in research-based intervention, was there resistance?
Short for Moreno Valley, there was no resistance from clinicians. They welcomed the capacity building. We started out with contracted service providers, and they understand from the clinical world, productivity. I mean, all of this work is really more germane to their work outside of the school-based setting. And so they welcomed the different capacity building, the training, the PD that we had, so that they could be more integrated into school teams that would maximize their productivity. So they actually welcomed it from that standpoint.
And to echo Raphael's point, it was more educating. It was educating our clinicians on how to be integrated on the MTSS framework, how to look at tier 1 approaches, and reducing stigma. But it was educating then our educational teams on the school sites, our teachers, regarding confidentiality, regarding just access, understanding treatment. We did a lot of case studies, case presentations at the onset of launching services, to simply have folks understand that the time spent out of class was in fact benefiting students and improving. So we really did a lot of marketing and education. And then we use students, obviously just data pieces to show the growth that they would make. The idea was to reduce the stigma from our staff, from parents. We have an interest survey for, as we created a comment form, we have a student body, about 18,000 students, and we can't keep up with the request for services. So we have to constantly update as to where we are. So in many sites, we have practically almost eliminated stigma. So I think that's key over the growth of time in the education. And going back to the integration, we have what's called child family team meetings. That's part of specialty mental health. In the school setting, it's kind of like a SST, a student study team, but this is really bringing in everybody that's providing and supporting student services. I have done 2 presentations to our principals, and they're due for another one on what that is, what it entails, and what their role is. So CFTMs, child family team meetings, are a regular part of what we do in our business now, whereas folks never even knew what that was or what it stood for.
Oh, that's great. Really nice to be reminded how important that is, just to calibrate, right? Share out to lead staff. I appreciate, Jose, how you lifted up some of the data points. Maybe you can speak a little bit more about some of the things that you kind of draw attention to that shows the impact, the positive impact to the academic culture, the behavioral culture, and the attendant culture in your schools. And how did that play out, or things that you glean from that process?
What I share with my team is we're in a school system, so therefore our data points are behavior, academics, and attendance. So those are the data points we'd go into our student system. Hey, prior to services, this was the GPA. After services, this was the GPA. We talk about the appropriateness of service. So like as we launch CYBHI, we have specialty, we have other services that are part of the MTSS system that we do not bill for. Those are entry-level services to open up the availability of other services, mentoring, for example. These are just intervention-based services. A couple years ago, we really focused on alternate means of corrections, alternative to suspension for substance use. We cut down suspensions for substance use or carrying substances by 60% because we're offering immediate services. So that was last year, and now we're continuing to refine that and look at the impact, but we're checking recidivism. So we're working with technology to create a report. Hey, these are the service dates prior, 30 days after, 90 days after. How are students doing then? And then catching kids that are reoffending and trying to re-intervene. That's our next goal. Look at that outcome data. That's for next year.
That's great. Well, I appreciate you lifting it up that way, especially for the folks that sometimes want to polarize on a perception that behavior mental health services is maybe not necessarily appropriate. So looking at the data is the best way to get refocused. So thank you, Jose.
Yeah, I'd like to add on that point if you for just a quick 30 seconds in that with this work with the County Office of Education, with this grant that we got into, it also enabled us to move into that MTSS pyramid on the lower tiers. Whereas before they would refer when students were in crisis or needed that tier 3 support. The school-based mental health, one of the grants that we received with our COE and with Jose and Jurupa, it was that how do we really collaborate at those tier 1 and tier 2 levels? And so now we're capturing data like classroom presentations, student check-ins, contacts. So our site staff, instead of seeing us as an outside support, some kind of an entity where they refer students out, we have a much bigger impact and presence on our campuses now.
Oh, that's amazing. Wonderful. Well, we are so excited about this presentation, and I know that we have one more question we're going to go to, but as a reminder for the folks, we are going to have Jose, Rafael, and Kathy, I believe Teresa as well, joining us at office hours on Friday for some additional questions and answers. So if folks, you didn't get your question answered today, please join us on Friday, and we'll continue this conversation, this thread. But I'm going to hand it back to Liz. I think we have another question.
Yes, and Kelly will feel free to use the Q&A form to submit it, and we can follow up at office hours with yours because I see your raised hand. And it's a pretty simple question, so I think we can close it out, which is, you mentioned creating a universal referral form, Jose. Is this something you would be willing to share with county offices of education?
We had a referral form and then we turned it into an interest form because we could not keep up. On our main district website, Jurupa Unified School District, you'll see a radio button that says behavioral health. And on there, it'll take you to our website. And then there is an interest form. So that folks, we have our business associate agreement with Google. So we do use Google Forms, but it is HIPAA protected. We do have signed business associate agreements. And it goes on to a Google form where we then follow up and we document everything there. But we receive over 1,400 a year.
Sounds good. And we'll also include that link in our follow-up information to the COP and also with office hours. So appreciate the question.
Well, this has been a robust dialogue and discussion. Thank you so much, Jose and Rafael, for your really in-depth presentation today and your ability to just think on your feet and share such important information. We really appreciate it.